Hello.
Hello. Hi, Irina.
Hi.
How are you?
Good, how are you doing?
I'm okay. The smoke is getting to us, but other
Oh,
than that, I'm
good.
okay.
Oh
Yeah.
no.
Well, it's much clearer today. You can see behind me the trees. Haven't been able to see them clearly all week.
Right.
So, to the fourth virtual water cooler session hosted by the STS Roundtable. Um, Ivan, my name is Pam Posey, and I'm a member of the Roundtable, and I'm hosting these sessions. This week, Pete Sorensen and Irina Kirstic are going to lead the discussion and facilitate the discussion around um, walking in the dark, healthcare workers in the time of COVID. And Irina, if you can go to the next slide, just to ground us all. What we're trying to do with these sessions is hold space for conversation, inquiry, and learning in an informal way that lets us build and sustain community. In the sense that, you know, we used to have meetings, we used to go to physically attend conferences, and in the intersections between meetings and sessions, we used to have conversations around the water cooler. And so that's what we're trying to create a space to do here. And I become the tour guide around the water cooler. And Pete and Irina both represent the stewards of the roundtable, and they're going to really guide the conversation. The agenda for the day is pretty simple. You know, first, Irina's going to provide a brief statement of the topic, give us a little background, set the context, and do some framing around the topic that we've chosen and to get us grounded in thinking about healthcare ecosystems. Then she and Pete will work us through a series of questions and that we may or may not answer, but they're designed to help guide our thinking, our conversation. And we sometimes do breakout groups. We're not going to today. We had decided that if there were 10 or fewer people, we would all work together on this. I think it's useful to take just 1 minute each today, since there are very few of us, to say who you are, what the organization is that you represent or company, and kind of what's your role in that. I think if we're going to talk about healthcare and we're going to really get into some of these issues, it's useful to know who's who. So I'm Pam Posey. My consulting company is called Eyes on Performance, and I am an organizational design and leadership development consultant working primarily these days in education, although my background is mostly in industry and manufacturing. Pete.
My name is Pete Sorensen. I'm currently on the stewards team, and for professional work, I work as an adjunct professor of engineering at Southern Methodist University, right now teaching entrepreneurism. And then I also have a consulting business and consult to a wide variety of folks, right now working with a city in the North Texas area. And as far as healthcare goes, I'm old and I have titanium knees, an electric heart, a glass eye. And so I've had a lot of experience directly with the healthcare system over the last 15 years.
Thanks. Irina?
Yeah. Hi, everyone. Irina Kirstic. I am also a steward this year, and my day job is as a organization design consultant at a boutique consulting firm called On the Mark. And we work globally and cross industry on really exciting projects, including healthcare. We are currently working with a hospital, so that's been really interesting during this pandemic. And my experience, which I'll touch on a little bit later, is really with my sisters who are on the front lines of this pandemic, working in a hospital here in Arizona. So
Thanks. Betsy.
Good morning, everyone. My name is Betsy Merck. I'm an independent consultant. You guys all know me except our fellow from Mexico, Monterrey. My company is Merck Consulting, and mainly the focus of my work is not at all in healthcare. I'm more like Pete, becoming the recipient of healthcare, and really on behalf of an aging mom. Recently, my work is very focused on leadership development, some national laboratory work, and more increasingly in the last 6, 7, maybe 9 months in philanthropy.
Great. Thanks, Betsy. Ivan.
Yeah, thank you. I am Ivan Hernandez. I live, right now I live in Monterrey, Mexico. And I found this group, I do not remember if Marcela from Canada contacted me. And that's the reason because I am here. I was trying to be in this kind of meetings, but this is the first time for me, and I am just hearing you. But let me know. Let me tell you what I do right now. Since 28 years ago, I have been a professor. I teach here at Monterrey Tech and a public university called UNI. And I also work as a consultant for executive and yeah, just for executive people. And I studied at Pepperdine University. I have a doctoral degree from 2010. I was at Pepperdine University, and at the very beginning, my career is a psychologist, organizational psychologist, and I have been working for 28 years till now. And here I am, and I will be hearing you. Thank you.
Thank you, Ivan. It's great to have you with us. Bert?
Yeah, I just want to say I'm so glad to see Ivan with us. Just a sidebar, Ivan. 20 years ago, I taught a number of engineers in Mexico City about socio-technical systems. So I've had a real interest in what's happening in Mexico around this work. But like Betsy, most of my work is in industry. I'm an organization design consultant from Vancouver, or near Vancouver, not in Vancouver, Vancouver, British Columbia. So I'm like you, I'm outside the United States. And but my interest around this has partly been the work that I've done in previous years around trying to bring healthcare closer to home. Done quite a bit of work in our province and Western Canada about 10 years ago on that. So looking forward very much to hearing what you have to say, folks.
Great. Thanks for joining us, Bert.
Well, thanks for doing this, Pam.
Hey, you know, it's all fun. We all need to get together and just have conversations, I think. Irina, how about if I just turn this over to you and you kind of set the stage, lay the groundwork for us, and then we'll just have a conversation.
Sounds great. So as Pam had mentioned, you know, we do these monthly and there's different topics, and today's topic is really centered around healthcare. So our topic is called Walking in the Dark, Healthcare Workers in the Time of COVID. And so I'll just set the context first and then we'll jump into framing. So the COVID-19 pandemic has really exposed some pretty monumental gaps in preparedness and planning to enable the US healthcare system and the workers to be ready. And this has resulted in, I'm sure as you all have heard, a lack of PPE, personal protective equipment, overworked and underpaid workers, and a true injustice to those that are risking their lives on the front lines of this pandemic. In particular, we'll be kind of touching on the US and kind of our knowledge with that. but I'm sure that there's also stories from abroad as well. And so the purpose of this session is to really explore the challenges for people in the field of healthcare, using healthcare workers as the focal point to look at the systems that impact their ability to do their work. And so if I go to the next slide, for the purpose of framing this conversation, we tend to look at healthcare issues from a bit of a triangular three-point perspective. So we have organizations and how we design them, the human systems and people perspective, which, as I mentioned, we're going to really hone in on that conversation for this session, as well as the future of healthcare. And so for the purposes of my personal framing, like I had mentioned, both my sisters are working in healthcare. They're both physician's assistants at a hospital here in Arizona. And, I never really thought of them in a position of being in danger until the pandemic. And when it started, they were calling me up and telling me about what they were seeing and what they were experiencing. One works in internal medicine and the other works in the ICU.
Oh,
So they're really, exposed in both departments to COVID patients. And so, when everything was still uncertain, and of course with our president kind of denying the situation, it was very much not a priority, and they were told to wear bandanas as their PPE because they did not have enough in their hospital. And they work for a very notable, very well-known hospital here in Arizona. I won't mention it just to not get them in trouble, but it is very unfortunate, the situation. And so, in addition to that, because of the amount of patients that they were seeing, they had implemented what's called a Jeopardy system. And so whenever their ICU or departments would reach a certain number of patients, they would have to be called in for an extra shift, or 2 or 3, depending on the situation. And so sometimes they would work for 6-7 days in a row, 12-hour shifts, again, being overworked and not being paid in overtime, which is the craziness of it all. And I think, Pete, you had sent us an article, and we'll forward that to you as well, on a lawsuit out of Texas on overpay and kind of the overtime work that healthcare employees are being asked to do, and just not being rewarded for that in financial or safety. So this discussion will focus on, as we mentioned, the human system, people aspect. That's my perspective and what I've been exposed to. And I became very impassioned politically to help them in any way I can, just because I'm not on the front lines. So I was calling Congress, anyone in politics, trying to advocate for more personal protective equipment. I don't know if what I did has made an impact. I think a part of it is the outrage, but a part of it is also just lower patient count right now. So I was telling Pete and Pam, they are at a place where it's no longer a lack of personal protective equipment. They still have a lot of patients, but it's much more manageable. And I don't know how much is that they were able to scale to meet the demand, and how much is just pure luck of just things kind of settled as things are. But it could have just been executed so much more efficiently and not put any of our healthcare workers at risks. So we may look at the design of implications of the systems perspective, such as supply chains, or from a purely human experience perspective. And it's important to look at all 3 points of the triangle, but touching on the human systems, again, that is my perspective, and we'd love to hear your experience with it as well. And I'll pass it over to Pete, who's going to set up some questions and some thoughts to stimulate the discussion.
A couple of things to start out, and like Irina, I feel like I've got some skin in the game too. Carolyn and I have a granddaughter who is a physician's assistant back in New Haven, Connecticut. She works in the neonatal intensive care unit, and her partner works in the emergency department, 2 different hospitals there in New Haven. And the stories that Corinne is sharing with us are enough to curl your hair. And same kind of things that Irina said in terms of PPE and extra shifts and so forth. We also, on another side of my family, my daughter's sister-in-law is an intensive care unit nurse in Dallas, and she's part of the lawsuit over overtime. And so we get a good earful from her about what the working conditions are that she's like. Personally, with Carolyn and I, she has had to implement COVID protocols in these two buildings that she's been executive director of. And in both cases, these buildings have dementia patients as well as assisted living patients who are moderately independent but still need quite a bit of support. And one of the most heartbreaking things, again, is being cut off from families and to be in your room in isolation and having everybody around you wearing masks. And so the human interaction is just the human interaction is intermediated by the mask and the gloves and the gowns and so forth. So it's very challenging. For me personally, I do have quite a few doctors, and what I've personally experienced is that a doctor's appointments being canceled and rescheduled, because there was so much stress on the hospital system because of COVID that they just were not, unless you were critical, you were not able to get healthcare services. In my case, not a problem because most of what I was looking for was routine care. I do have psychiatric help. Because of my service in Vietnam, I have been diagnosed with PTSD. And now the thing that's nice about the psychiatric help is that we've been able to do it over video and telephone. And so I've been able to have that kind of care fine. And of course, prescriptions have all been through mail, so that's manageable. And the Veterans Administration that I work with has a good online system, as do the other healthcare systems here in the Dallas-Fort Worth area. So we have portals, we have access, and that is really helpful. But there are all of these other things that are pretty darn scary and pretty darn out of our control. Okay, so we're going to have a couple of questions just to kind of get us thinking. But I want to make one more comment, and that is, as we've been organization designers over the past 50 years or so, we started out working mostly at the team level, and a lot of our work was done in manufacturing facilities. We went from a team level of design to an organization or a plant level of design. But now the level of design that many of us are working on are on the ecosystem level. So it's not just an intensive care unit, but it would be a whole hospital system, and the hospital system living in the context of a global marketplace where the supply chain can't get us personal protective equipment. And so one of the things we want to be thinking about as people that are focused on organization design is that it is necessary for us to design at each of those levels. And I didn't even mention the psychological level, right? Person to person and within our own headspace. So, so it's a very dynamic kind of notion about the levels of thinking that we need to get after in here. But right now, let's focus on what's your experience been. Irina and I have shared a couple of our experience, but what for you guys has been the experience of the healthcare ecosystem since the beginning of COVID?
Well, speaking from a Canadian standpoint, Pete, there's a few things that I would just offer as observations. And I'm not sure whether this holds for Mexico or for the United States. Just one general thing. I thought it was interesting this morning, just came out from the WHO that 1 in 7 cases of COVID in the world involve healthcare workers. 1 in 7, just healthcare workers. So there's obviously a very high level of exposure there. But so there's a lot of things behind that. In Canada and in British Columbia anyway, I would say that also in terms of deaths, that a very high percentage, the majority by far of deaths have involved elderly people in residential homes. Which also brings me to a third observation, that I think one thing that's becoming very apparent is that we have underplayed the whole notion of public health or community health. If you think about the whole development of the virus situation in our country anyway, really the hospital setting is not the place where this is managed or controlled. It's in the community and the way that people behave and function in the community. So I think our notion of healthcare work is really been broadened by this experience, if we're honest. At least in the Canadian environment anyway, I would say that. So I'll leave it at that for now.
Excellent. Thank you, Bert.
Oh, Betsy, I think you're on mute.
Because of my mother, I just made a list thinking about the experiences I've had with the healthcare since COVID, and it's really been phenomenal. My mother was originally in June. She was in a senior citizen, just not assisted living, just an independent living, but she had a full-time caregiver. Some of the people, a couple, husband and wife in the facility, went to the hospital for care, and the woman came back positive, gave it to her husband, and the caregiver for my mother was also helping this couple. The caregiver then needed to be tested. She told us she tested negative. But Pete, I'd be interested in Carolyn's procedures. Where my mom was, they did not ask for a copy of the test. So she was in the facility working with my mother and all sorts of other people for 5 days before the county contact tracers called the facility and said, she's positive.
Yeah.
So then she was out, she contacted, but I don't believe anybody else got it, including my mom, which is really interesting. And then that kind of started our journey moving my mom. So there's one where I thought the procedure should be ask for a copy of the test. And but no one was talking to me about that. I couldn't even get to the corporate. This is a facility of like 126 across the nation. Mm-hmm. I couldn't ever even get to the corporate people. They would never let me get through. But to my knowledge, there was no reckoning about, we should have asked for a copy of the test. So that was kind of interesting.
And Betsy, that's one of the things that Carolyn was always very careful about, is that anybody's test, they had to have paper copies to be able to establish and verify. And with any employees that were ill, not just with COVID, but with any kind of illness, they established a protocol where they had to have a doctor's clearance to come back to work.
Right.
So, yeah, that was pretty sloppy.
And I think in Marion County in Oregon, it was my understanding, they had to have the county's okay to go back to work.
Okay.
So the county was tracking it. Mm-hmm. So there is an independent facility, senior citizens, doctors not sending out a test, the individual not asking for a test. The county was on top of it, but 5 days later, so I don't know the process from the minute you get the test results to informing the county and how many personnel they have to then get back to the resident and say, oh, by the way. So that's just one example. And then recently, because of the situation last week with my mom, I started thinking, should we move her to Oakland where I could see her all the time, even if it's through glass? Yeah. So I went and interviewed and spent time yesterday with a facility very close to me. They've had 5 COVID in the last 3 weeks, and not at the beginning, but in the last 3 weeks, all brought in, of course, from their staff assistants, right? The workers. What the general manager told me was all the workers were asymptomatic.
Yep.
So I don't know the procedures, I have no idea what you should be doing, but they had 5, and this is all memory care unit. So it's wildly out. And her response to me, and she seemed like a lovely person, but she said, I don't think it's possible to keep COVID out. And, and I went, oh, okay. And I'm thinking, well, this isn't the place for my mother, but, there's something to be said about how difficult it is to manage it. I don't know what the procedure should be, but, and the other thing I was thinking about stakeholders, because in the United States, and Yvonne and Bert, you guys, I don't know Mexico well enough to know, Yvonne, but recently I was looking to maybe we'd like to go to Mexico for Christmas. And the U.S. State Department, you'd be curious, Yvonne, you ought to look at it. They have warnings all over that pop up about travel in Mexico. And mind you, how bad we are in the United States on COVID. But warnings about COVID in Mexico and crime. So it made me think, I don't know what the truth is. I don't know if I should be going there. But, travel and information and getting information. But my point there was how political it has become. So I'm wondering, to go back to our question about stakeholders in the ecosystem, even in the local, to go back to the public health, should the hospital systems, I would think, in any kind of design efforts, be working with the public health officials? I don't know. And I'm not doing any of this work. But I think this is the last thing I'll say, in the California, you guys probably read, I think the clarion call was the public health worker, the head of public health in Santa Clara County. And she's the one that said, close it down. She early on, she really is a hero in my mind. And people really listen to this woman. She has a great deal of influence. So I don't know. That's what I'll say.
Betsy, you raise an issue for me, and I don't want to divert the conversation, but Pete and Irina and I were talking about the concept of ecosystem versus system just before you all joined us on the call. And I originally was saying, I wonder if that's going to be confusing as we think about this. But Betsy, what you raised for me is the notion of it is an enormous ecosystem, and we have focused most of our attention and most of our resources on COVID.
Right.
At the expense of other critical pieces of the system.
Right.
And what's the long-term impact of that going to be? We have people who are going without regular primary care stuff. We have people who are avoiding hospitals who are in critical conditions from heart conditions, and we have people having strokes who don't do anything about it.
Right.
Because the ecosystem has become lopsided with its focus on COVID for obvious reasons. But it's interesting the impact on the whole system that it's having.
Right, right. I've wondered the same thing because I've deferred all, what I call tune-ups.
Yeah.
All tune-ups have been deferred since this, and I had melanoma. So I would like to get a skin test. I'd like to get the tune-up, and they're telling me at Kaiser, oddly, and I have to pursue this on my list today, no, the dermatologist cannot see you, but your primary care physician can see you. So let her take a look at you, and if she sees something suspicious, she'll send a photograph. Well, if she can see me, why can't the dermatologist see me?
Yeah.
It doesn't seem to make any sense to me.
Yeah.
So that's an example, though. What will happen with all the deferred maintenance, if you will?
Yvonne, would you like to share anything about your experience in Mexico?
I am just hearing all of you, and I am thinking about what will be my own response. And that then let me tell you that I had bias. I had been for 6 months fully closed. I mean, I am healthy and I am working and I am an overeducated here in Mexico.
Mhm.
And my perspective is from a biased point of view. If you read or hear the media, here in Mexico, things are not too good as at states. I live in a state that is one of the most richest here in Mexico. We have 32 states, and here in Monterrey is one of the most richest states in Mexico. But we have a lot of poor people, and the media is not a good source to know things. And here in Mexico, we have a federal government, I mean, a president that it is not, that he is not smart enough. And he is not surrounded by good advisors. And the numbers that we have here are not consistent, even though it is official. I don't believe on those numbers. And I don't have, sorry about it, guys, but I don't have a good perspective for health systems here in Mexico. There are plenty of poor people that will be suffering and that are suffering from this pandemic situation. Sorry about it. I don't have information, and sorry. Please apologize me. I don't have a good perspective or an optimistic perspective. Here in Mexico, we have a lot of political, economical, societal, even academic issues. Big, big, big issues. And that's what I can bring to this table. And that's the reason, because I told you that I am just hearing you, just to hear.
Mhm. Mhm. Mhm.
Okay, that's all, folks.
Thank
Sorry.
you.
Thank you.
Thank you, Ivan. Thank you. That's helpful. That's provides some insight. Very helpful.
And we share some of those issues as well.
Right.
lately.
Yvonne, as you were talking, you're not the only one. We could go right down the line. Unfortunately, for the United States, we have exactly the same issues. They might be different in size, but we have very similar issues.
It's interesting. You talk about the information that is available to us, and of course, you would use the word disinformation that's available to us, and the rumors, and here in the U.S., conspiracy theories and so forth. All of that represents a great challenge in terms of sorting out what's accurate, what's true, what's actionable. My daughter, Laura, has 4 children ranging from age 6 to age 16. And she and I were talking a month or so ago, and she has a horticulture degree from Texas A&M University, from a very rigorous scientific background. And she said, "Dad, I can't figure out what's true and what's not, and what recommendations I should be following." She said there are so many contradicting pieces of information and sources of information that that seem to be biased and perhaps politicized would be the best way to phrase it. And we had an interesting talk about that, of how do you sort out information to find accurate information, and then how do you choose to act on that information once you've figured out. So I see, do you guys experience that also? And where do you get information that you feel is reliable and valid?
I'll just speak for Canada and British Columbia. I think one of the things that has worked well in Canada is that the politicians have allowed the medical experts to be very visible and active in providing information. That's personal experience. So basically the information is trusted, I would say, in Canada. And I would, again, I don't want to sound like a broken record here, but I do think COVID, the whole experience exposes, and when you talk about information, the importance of getting information to the community and key actors in the community.
Right.
Because I think this is going to be more managed in the community than it's going to be managed in the hospitals. I mean, just think of what is critical in terms of managing it at universities, for example, and colleges. That's where the public health information needs to go, into those, and the schools, and into those active parts of our community, rather than thinking of it just as something that's managed through the hospital. So information becomes key. We've been quite fortunate, although, you know, there's always the need to be more informed, but I would say at least we have information we can trust.
Hi there.
Hello.
Adam
Welcome.
Daniel here, Ottawa, Canada.
Oh, welcome, sir.
Thank you. Yeah, very interesting topic of conversation that I've been reflecting on very deeply for the last several months, because I myself felt a lot of personal conflict around the truthfulness and accuracy of a lot of the information coming out around this pandemic, and it kind of provoked some deep philosophical reflection. I just want to share a resource. I've been following a gentleman by the name of Daniel Schmachtenberger. I don't know if anyone's familiar with him, and he's specializes in like systems design and analysis, and working on an interesting project about like prototyping the redesign of human civilization. And he emphasizes the need for the importance of like sense making, like as a foundational practice for building a just and harmonious and functional civilization. And I think that also applies, you know, at the organizational level. And I'll share a link in the comments, but I've been following quite closely, and it's very useful in terms of the insights that he gives in terms of that, just collective sense making, and just being aware of a lot of the different sources of information and the potential biases of those different sources of information, and how that relates to, you can't take a wise action without effective sense-making processes, and wise action is an underlying foundation of building just and harmonious and functional systems. Yeah, I can really relate to this fundamental challenge here, because there's so many different forces at play that I think are affecting the accuracy and truthfulness of the information that we're exposed to. And I myself, in terms of my sense-making process, is that I'm making a very deliberate attempts to explore independent media, independent sources, even independent scientific sources outside of mainstream medical authorities, because I think that there's seems to be indications that, you know, financial interests are affecting some of those narratives. And so just, you know, I'll follow scientists on YouTube and I think that's really cool about social media now, is it empowering a lot of just independent researchers and practitioners to do completely independent analysis of research. They'll look at raw data and then they'll give their own opinions about what's going on. And I think we're much more likely to get unbiased perspectives of what's going on there. And that's been my approach. You know, I'll follow the mainstream media, but, you know, increasingly disillusioned with what I believe is the accuracy and truthfulness of the way information is presented in the mainstream media. And so been very much looking towards alternative sources. And one of the perspectives that, or one of the principles or practices that he recommends in terms of sense making is something that he calls steel manning. So if someone has if there's a narrative that we don't agree with, or some sort of source of information, to try to empathize and take with the other person's perspective or the alternative perspective and try to look for all the reasons why that might be correct. And then to do the opposite and look at what are all the potential biases of that source or that person, and what are the reasons why they might be untrue or incorrect or misled, and to do that for all the different perspectives. And doing that you know, holistically or broadly is where we're most likely to have the best probability of having an accurate approximation to the truth. And that ultimately that needs to be done at a collective level. You know, if we're talking about human civilization or an organization. So I'll stop there because I know I'm rambling, but anyone have any thoughts on that?
I think what you're saying is very important, Adam.
I think one of the things that's kind of interesting about what you're saying, Adam, and I like the idea of taking the other person's perspective and thinking through all the reasons why it might be right. And then having them kind of look at our perspective, whatever, and look at all the reasons why it might be right. But today, before this call, on a real famous kind of Bay Area talk show, you know, on KQED, on public TV radio, they were talking about the upcoming debates and the role of the press.
Yeah.
And how are we going to manage, from some people's perspective anyway, all the untruths that are anticipated from one party, one member of that, you know, the Trump, right? How are they going to stop and correct him to get the truth during the debate? And these people on the panel were saying it would be impossible. You would never have a debate. So how do we get in the fast movement of data and information and a continual barrage? How do you do what you're suggesting? Do you just pull the critical few? If you're working with a group, what are the critical few issues that we really need to understand, or maybe getting in our way, and we kind of dissect them, as you will, as you're suggesting? I find it kind of overwhelming.
I mean, I certainly agree with that. I can relate, and this is why he emphasized the importance of that process needs to be done collectively, because you know, the degree of complexity is at such a incredibly high level that it's impossible to make sense of complexity at an individual level.
Mm-hmm.
You know,
Yeah.
one of the things that the academic, you know, teaching part-time has been helpful to me is to try to sort out, like we're saying, fact from fiction, and what sources of information can you rely upon, and what do you need to be very cautious with. And in the chat, I went ahead and put a reference to a website called Calling Bullshit, and it's based on the work of Carl Bergstrom and Jevin West, and they're professors at the University of Washington in Seattle, and they have been teaching a course for the last several years at the university that is an interdisciplinary course looking at this issue of calling bullshit, of identifying bullshit and calling it. And now they've published a book. And this website of theirs I've used as a reference point in my classes for the last several years. I'm even considering seeing if I can get clearance to use the book, but we'll wait and see about that. But the thing that I've been concerned about also along this line has been that our critical thinking skills and our ability to use evidence-based thinking, I worry that as a society collectively, we're not as good as that at that as we need to be. And so I've taken an approach in my teaching of, in all my classes, having an introduction on the basics of critical thinking, which is some of what West and Bergstrom are doing. And I've even included with my consulting clients little mini lessons on this topic of how do we think well? How do we think critically? I think it's a big issue in our society, and as we design organizations, it's got to be a big issue for us. And as we deal with healthcare, it's got to be a big issue for us.
Yeah, I completely agree. I've talked about my direct source of knowledge and what's going on. And luckily I have a client as well who is a children's hospital and just kind of seeing how they're going through the COVID and what their healthcare workers are having to go through. But there are, of course, the people who don't have any direct contact with any healthcare or hospital facilities or any personal connections that do just listen to the mainstream news and maybe just don't even listen to that either. And they're kind of in this selfish bubble of, well, life's got to go on sometimes. And so they're so socially distant is not really in their vocabulary. And they go on these big outings. And I just recently saw one of my friends who is also a healthcare worker in Seattle, Washington, write a very long, lengthy post about her experience with a patient who came in and, was coughing but wouldn't keep her mask on, would take off her mask and just kept coughing. And they asked, is there any chance that you think you might have interacted with anyone with COVID? And, she told everyone, no, absolutely not. And then come to find out later, she had a chest x-ray as well that came back very COVID pneumonia-like symptoms. And when they called to tell her, she said, oh yeah, that makes sense. A lot of the girls that I just went on a wine cruise with, they actually have the same symptoms, and some of them tested positive for COVID. So that kind of selfish bubble of just going to your healthcare provider, which is expected. You have to find out what's going on, but to not put on the mask and to not keep it on while you're coughing is just tremendously selfish. And that's just a lot of what we're seeing in society right now is either selfishness or just ignorance and choosing to just ignore what's happening in healthcare and the human ecosystem.
I just put another bibliography in the chat from Edward Tufte, and he's another person that I look to in trying to sort out truth from fiction. And he also does a great deal of good work on how to array, display data as we work with people and groups. The whole, how do you do visual depiction of information accurately? So that's another resource. And by the way, the first entry in the chat was a little short bibliography about articles that Pam and Irina and I had come across recently that were interesting healthcare related articles.
I also posted a link from Daniel Schmachtenberger. It's from a video from a channel I've been following called Rebel Wisdom. And the name of the talk is called The War on Sense Making. It's a 3-part series. And I believe that he actually references, not in that one, but another talk, he does reference Edward Tufte. He talks about his work. And there's a couple more videos I might post if anyone's interested. They're a bit lengthy and kind of heavy on the jargon. I've had to watch them a couple times each, but I do think it's really worth diving into. And thanks for those resources, Peter.
Well, thank you, Adam. Those I just pulled that up, so it'll be one of my next things to watch. Thank you very much. And of course, Kyle Weick is one of the people that introduced all of us to the idea of sense making, and that it's an essential thing for anybody in organizations, and especially org designers and leaders. So good stuff. Thank you.
Irina, can you say a little bit about what you've learned from your experience working with the Children's Hospital around this whole question of the healthcare workers in COVID?
Yeah, so it's actually, we're doing an organization redesign with them, and we started before COVID, and they decided to continue during COVID, and it's actually been astonishing how similar the process is to prior to COVID. You know, they're still going about trying to figure out how can we optimize the way that we're working, but at the same time, obviously, you know, thankfully it's a children's hospital, so they don't have as many cases, right? It's not something that thankfully is happening in our children as often, but they have had to adjust the way that their employees work, their schedules, again, having to step in different situations that they have not previously had to do. So in the context of the redesign work that we're doing, it isn't impacting it, I think is the big insight for me. It's not impacting as much as I thought it would. And maybe if it was a hospital that had, you know, a COVID influx of patients in older ranges, maybe we probably would have stopped the redesign. But I think the fact that it is a children's hospital, it has been mainly focused on how do we make our employee experience comfortable, making sure that they don't feel overwhelmed, making sure that they feel supported both mentally, you know, outside of their everyday work, and taking care of them as we go. So it's been really great working with them.
So there's two things that you made me think about, Irina. Yes, I mean, I agree that there's probably not the COVID experience in a hospital, but maybe, as you said, it's heightened the need for the hospital organization to think more carefully about their workers' health and their well-being in being able to be at work.
Mm-hmm.
And right? So, because I think that maybe hospitals have been more focused on patient care as opposed to care for their actual workforce,
Mm-hmm.
who in the course of work are exposed to all sorts of potential disease.
Mm-hmm.
That's one thought. And I had another thought and I just lost it. Oh yeah, it's the fact that it seems to me that one of the differences might be, and I'm interested whether this would apply to this hospital, that hospitals tend to be doing a lot more testing of their workers than is normal within our larger society. I mean, getting proper testing has been a huge issue, certainly in Canada, the United States. Quite aside from the number of tests, it's the timeliness of testing process and so forth. But it seems to me, I'm wondering, do they actually test their staff regularly at this hospital?
I don't know how regularly. I don't have the answer to that, but I have heard that you know, they've initially did do some testing with that specific hospital. With my sister's hospital, different story. They actually did have a coworker that they work closely with test positive for COVID, and you know, I think that maybe they took some, you know, a week off. I don't think it was 2 weeks, you know, the recommended period, and they were not required to get a negative test to come back to work.
Oh,
Which is astonishing. So That was a really, again, another kind of, we have our peaks and valleys of fright, again, having my sisters in that profession, but that was another peak of, well, now what do we do? You know, if they're not even enforcing that, that these people who are testing positive, not to, you know, it's not like it's their fault, but that they aren't required to have a negative slip of proof to come back to work. So, yep.
And then, of course, there's the implication, right, for society to go back to kind of the ecosystem. I would imagine, I don't know where your parents live in relationship, but I thought they were pretty close to your sisters.
Correct, yeah.
So I would imagine that's totally disrupted, that your sisters don't feel like they can be around your parents.
Yeah, I mean, especially initially in the beginning, we have, you know, my parents are thankfully healthy and on the younger side, but we have my grandparents, and my sister has a baby son, my nephew. And so my sister has a whole process of what she does to decontaminate when she comes home from work. And, you know, unfortunately, she can't wear a mask around her son 24/7. He's a baby. So there's definitely some things that cannot be done, but they are very extra cautious and try to wear masks as much as possible.
Just an anecdotal story from within our family. We have one of my wife's daughters who's a very talented, intelligent, capable, delightful human being. But she has listened to the voices that are on the end of the information spectrum that you might call COVID deniers, or at least COVID downplayers. And so they were not using the CDC recommended basics of masking and washing and sanitizing and so forth, and distancing. So word about that got to, of course, her sister, and then to my wife, Carolyn, her mom. But the place that it really went to was to our granddaughter, who's the physician's assistant. And our granddaughter called up her aunt.
Great.
And gave her a tutorial, an individual tutorial about what's really going on from a healthcare and personal experience perspective from Corinne and Danielle, her partner. And Carolyn said that our daughter's attitudes and practices turned around 180 degrees instantly, because she had good, accurate information that she trusted from a trusted source, who is a source that is not only her niece, but somebody who has expertise and frontline experience. Would that could happen to all my friends.
Yeah.
Mm-hmm.
Right. Well, Pete, that's an example at a micro level of what this conversation has provoked in me personally, anyway. The sense that organizationally, we've got to address this much more in the community environment than in the hospital. I mean, the hospital's dealing with disease, the community is dealing with health.
Right.
And I would think that the wise approach would be to develop those kind of mentors throughout our community. You know, when you think of Kurt Lewin's work and all that around social change, mm-hmm. People get influenced by those they trust. And we need to understand the networks and get them proper information and coaching and all that sort of stuff if we're really going to address it. And I think the importance of this is that COVID is likely to be with us for at least another 24 months.
Family, see it for me? Yes. No, I'm not.
Sorry. You know, and I think the COVID experience puts tremendous pressures on us as human beings. You know, we talk about physical or social distancing, but it's not a natural pattern of behavior. And so really, to address the risks in COVID, you really have to address behavior in a way that's very challenging, if we're really honest, I think. And particularly looking at different socioeconomic class groups, there are some that have less choice in how they interact than others. I feel very privileged personally, but it's not enjoyable what I go through, but at least I have more control over that than a lot of other people that are in very exposed situations, just as a matter of work.
You know, to your point, Bert, my son is a really socially active guy, and we've been talking a lot about his feeling that the public health system in California is just completely inadequate in terms of public campaigns. And just having done these drive 2 times in the last 2 months, in Oregon, you know, the big signs that are over the freeways, there are signs up and down I-5 that say the virus is still spreading, keep your distance. There is nothing in California, which is really interesting. You would think, so I totally agree that we have to manage this at a local level. You know, we don't want, if you get to the hospital, you've gone too far, right? You failed.
Yep.
So managing it, there's so much more we could do for public health campaigns that we're just not. I can't tell you the reason we're not, but it's very inadequate and it's very obvious.
You know, Betsy, you've heard me say this probably ad nauseum, but I'm struck by the fact that Paul Lawrence, when I was a doctoral student, used to say to me just about every time we would meet about my dissertation work, you know, what you find, what you see depends on where you're standing when you look for it. And we don't always, even if we can choose, we don't always choose wisely about the perspective, the point we're standing. So COVID, if we know someone who's been exposed, we know someone who's had it, we're standing in a very different place than we are if we're the medical director of a healthcare system unit, or if we're, dealing with an elderly parent, or we in fact are older. What we see, the extent of the system we're going to deal with is different.
Yeah.
And each of us comes from a different place. And so I love the notion, Bert, of hospitals dealing with disease and communities dealing with health. I think that's really important as a starting point. And managing locally may be the only way we know how to deal with something this complex. I've been sort of looking at the questions that Pete and Irina put out here, and I'm going, what is the healthcare human ecosystem? How big is it? What's part of it? And how much of it can I see if I'm, trying to deal with this and think about how to create a better design that works? That's pretty scary.
Mm-hmm. It's overwhelming.
What would you say? We've talked about our experience, but we've also talked about question number 2, which is really about what the ecosystem has been challenged with over the last year.
Right.
Could you guys think about and comment about any more about challenges in the healthcare ecosystem that you guys see? Address that directly. Is there anything that we haven't put on the table that would be stuff that we probably ought to put on the table if we're redesigning that healthcare system?
Well, this is only a piece of it, Pete, but like I said, in Canada anyway, such a high percentage of our deaths have been in the whole area of senior resident accommodation. And I think one thing that will come out of this, hopefully, is to treat elder care as part of the healthcare system. I don't think it's been looked upon that way. It's been looked upon as a housing issue rather than a healthcare challenge.
Okay.
I mean, that's only a fragment of, but I think there's been a huge challenge around the senior residential care.
Oh, huge, huge.
Yeah.
Huge.
Exposed all sorts of gaps in that area.
Yeah, when Carolyn was doing one of her internships before she got her degrees in gerontology, uh, uh, she came home one time and said, much of our elder care industry is a warehousing industry.
Mm-hmm, mm-hmm.
And that led to us having an alarming and startling conversation, because I had never thought of it that way. And she had been doing work as an ombudsman for the Area Agency on Aging, going in and investigating complaints in nursing homes, skilled nursing homes. And she came back just a little bit rattled from this one visit that she had made. I think that's a great challenge, Bert, really do.
I'm really living that, and it is really horrifying. In the first place where the woman tested positive, when we went to get our mom, who we hadn't been able to see since the middle of March, right? Closed down. Don't come in. She can't come out. We didn't have any view on her, which we don't, to all of you, don't ever let that happen. And the healthcare worker had the facility change the doorknob to lock my mother in her room. And my mom had bruises all over her arms and her legs, and which the very first thing, she has very little language. And she said to my brother, as my brother went to pick her up, the first thing she did, sitting in her chair, was pull up her sleeve and point to her arm and say, hurt, hurt, hurt. And she'd lost 22 pounds in 4 months. We don't know, no one, and now she's gained 5 pounds. It's not that she was at the end of life and ready to not eat.
Yeah.
She somehow didn't get anything to eat or was too frantic to eat. We don't really know. So I totally agree with you, Pete, that what I see, it's all about resources, right?
Mm-hmm.
And as a culture, at least in the United States, I can't speak anywhere else, but in the United States, I did read just the other day, looking at all this, trying to figure out what we're going to do. 80% of elderly still stay at home, are still cared for by their family. So it's not everybody, because going into a treatment or a residential or a memory care, whatever you call it, is expensive.
Yep.
But even at the expense, the healthcare workers, because we're starting to ask these questions. In Salem, Oregon, one of the healthcare workers taking care of my mom currently makes $14 an hour.
Yeah.
Paid her what she was worth, because I ran the numbers trying to think this through. It would be about $28,000 a month.
Yep.
Who could do that? But who can also even do like $8,000 a month or $10,000 a month? And in the States, if you have some measure of resources, what we have done is shunted these people off, my family included. We're right in this, and really asking Black and brown people, because that's who healthcare workers for the main are, not totally, to take care of our elderly. And oh, by the way, you're not going to get paid much to do it.
And Betsy, just insider information that in many cases, those healthcare workers that are doing the direct care with the residents have little training.
Oh, I know, Pete.
Many of them have a lot of compassion, and they're great people. But as you said, they're earning minimum wage, and so a $14 an hour, that's pretty good in some areas of the country for an elder care worker. And that's one of the things that Carolyn always struggled with, was that she had a budget that she had to operate by, and had to watch very carefully what the wages were, and it's the whole financial part of that is scandalous.
Yeah.
And then you look at these people who are delivering the care, and you say, okay, so how about health care for them and their families? How about transportation for them? How about housing for them? How about education for their children? And it comes back to many of the same kinds of issues that we have with migrant labor that we've talked about.
Exactly the same. We did ask this one woman, and what we found out, I don't know the truth of it, but what she said, she works full time. She doesn't get overtime, to Irina's point. She said they manage. She wasn't sure about her hours. She herself wasn't sure, but she said she doesn't get overtime. She told us she got dental care and eye vision care, but not health care, which we couldn't understand that.
Yeah.
And she's 21, has an infant, and lives with her grandmother, and she's Latinx. So here you have a dense living situation where she's much more likely to pick up COVID, as we know, right? No opportunity for any distancing, coming into the most vulnerable. She's lovely, but has no training.
Yeah.
She doesn't have access to healthcare herself. I mean, there it is.
Yeah.
And this is the best facility Salem, Oregon, the capital of the state, has to offer.
Yes.
Yeah.
So I apologize. I'm going to have to leave the cooler, but it's interesting. The reason I have to leave is related to the discussion in a way, because well, one of the ways in which I try to offer some care to my twin brother, who is disabled and so forth, but lives at home, is by contacting him every day and virtually. So I need to contact him, but I certainly try to make sure that he doesn't have to go into a hospital as much as possible, or into a residential home. He lives on his own, and he has people who do come to him who are funded publicly in our country.
Yes.
So anyway, I apologize, but I have to leave. But it's been really good seeing everybody, and nice seeing you, Yvonne.
Bert,
Bye, Adam.
Bert, would you
Nice
please,
seeing you. Take care.
Bert, please tell your brother we said hello.
Yes, I will. Yeah, thank you.
Okay.
Please let me tell you something, dear Pam and all of you guys. I apologize myself. I need to leave you in this moment. I have a lecture I have to lecture a class. I hope to see you again, and please take care of yourselves. Thank you
And
very
you.
much for this opportunity, and I hope to see you again in the near future. All the best for you and your family. Thank you.
Take care too.
Bueno, amigo. Gracias.
Yeah, best of luck.
Ciao.
So Pete, let me jump in here a moment. We've got about 6 minutes left, and I'm thinking that maybe we should call for some final observations or comments and wrap up this discussion for the time being. We have another water cooler scheduled on October 15th. But for now, how about a final observation or comment from each of us? And then we'll see what we can do to close it out and go from there.
Adam, why don't you go first?
I was going to wait for somebody else to go first, but since I'm on the spot,
Yeah, there you go.
so I came in late to the meeting. I've just, just my intention is mainly just to reconnect with this community. I actually first met a few of you, Pete, Betsy, and Bert back in 2014 at the Montreal Roundtable. You probably don't remember. I was a student of Don Daguerre's in the HSI program in Montreal. So I just wanted to, Don was my academic supervisor in
Great.
HSI. And so I first plugged into this community through via Don. And just wanted to reconnect with you all. I came in late, and so missed a little bit of the context to the discussion, but happy to be part of it. And yeah, really happy to just connect with you all because I know there's a wealth of wisdom and experience in this community. So.
Well, we're delighted to have you here, Adam, and grateful to have that connection that we actually do know you. And we are also saddened greatly by the loss of our brother, John Fuller.
Yeah, I just found out about that yesterday, and yeah, I've been reflecting a lot on it because I knew Jean as well, not very closely, but it's very tragic.
Yes.
You know, I'll comment just a summary. It's great to see you guys again. I kind of lost contact because I have been very focused on my mom. I don't know if this is what we wanted to have happen in the water cooler. You know, for me, it's kind of cathartic to be able to talk about this because I'm so in the middle of it. But I don't know, and I'd be interested to go back to Adam to make the water coolers more, even better, even richer, beyond personal connection. I don't know, is this meaningful? I feel like I was just kind of sharing experiences, but I don't know if that's what people wanted.
Well, I enjoyed your comments and participation, and I feel like the intimate nature of the conversation was extremely valuable, and I think, Pam, as you did your introduction, we were talking about the white spaces at our conferences, and that often those conversations were both intellectually stimulating and what I would define as intimate. So I think this has been a good discussion, and your contribution, Betsy, has been absolutely wonderful, both in terms of the COVID-related, healthcare-related stuff, and the fire and smoke and devastation of Oregon and California society. Those are critically important ecosystem things, perspective things. So thank you for what you shared.
Yeah, I agree that it's been cathartic for me as well, and it's important to share these stories to know what's going on, and again, hear people's experience with what's going on out there. So thank you for sharing.
You know, I think early on and Betsy, you were there when we had the first water cooler session, we really said we just needed to create a space where we could talk about whatever was on our minds. And we would sort of throw a topic out and put a few questions out and see what was on people's minds. And I think that's precisely what's happened today. Maybe we didn't get real specific answers to how do we design something, but we talked about what are some of the challenges around information and this notion of worker care versus patient care, which we don't talk about very often. Bert's comment about hospitals dealing with disease and communities dealing with health, I think is an important perspective. Your sense, Betsy, of managing locally. We sort of talked about personal stories and then began to look at how those help us understand the organization. I'm not sure we got really to the ecosystem level, Pete, but we started to say, what are some of the pieces of it? Yeah. And so, you know, and then the notion of how do we get truth? How are we sure we gain truth is important. You know, where do we start design? Do we need procedures and policies? Do we start with a larger system? You know, how do we do this work that we know needs to be done? So I think we've kind of talked about some of all of that today. And so for me, that's been enriching. And Pete and Irina, thank you for pulling this together, for putting your thought into it. And I need to thank the Roundtable again for sponsoring a water cooler session where we can all just sit and have a conversation with one another. And I really appreciate that. Our next water cooler, as I said, is going to be on October 15th. I should have the title for that in another week or so. But I'm not going to even give you a hint around what that's going to be, except that we think it's going to be exciting. And we'll send an announcement out in the next week or two to let you know what it is. If you want to help facilitate one of these sessions, if you have an idea for a topic for one of these sessions, Pete and I both have email addresses that are on this slide, I think. Are they still there, Irene? I can't see the bottom of my deck, so.
We're on the bottom, yes.
Okay, so please let me know, let Pete know, and we'll incorporate that into future water cooler conversations. And thank you all for being here. Pete, I usually let you close it out as president of the stewards team and the roundtable. So why don't I let you do that? And thanks, everybody. It's been great to see you.
Well, I have to apologize that I don't have my president's crown anyplace close, but I'll try to.
Presidents don't get crowns, Pete.
Oh, we don't?
No.
Oh, okay. Well, I'd like to propose a resolution to the stewards. So, Irina, be ready. The genesis of this really comes from a stewards meeting where Irina came to the meeting with her hair on fire. And she related to you what that was from with her two sisters and the intimate experience that she was having with the challenges, personal challenges that we're facing. And Irina did, as she said, engage in activism to be able to try to do something about it. And that certainly is a core value that we have as the Roundtable. That we want to actually make a difference in our society and make a difference for human beings. So thanks everybody for being here and joining us in this intimate gaggle and intimate discussion. And I will walk away with numerous ideas. Adam, the videos that you shared with us about sense making, and I am so grateful for you guys. And as Jabba the Hutt said to a bounty hunter in the Star Wars movie, you guys are my kind of scum.
Thank you. And if I can say also, I really appreciate it. I love the title of of our conclave today. I thought the title was really great and it was intriguing. It pulled us in. And Adam, join us. It was great to reconnect with you. I forgot that from 2014, and come join us. We'd love to.
I will. Yeah, thank you. It was great to reconnect with you all. And I'd be very interested to continue some of these conversations at a later date. So.
Great.
Terrific.
Great.
Okay. Thanks, everybody. Have a great day.
Okay, thank you, everybody.
Great day.
Here's a little hug for us.
Okay.
There you go.